So today I will be summarizing some important points about anesthesia, and this is for just for the last minute and last minute preparation basically because you should have done the whole chapter of your study or whole subject, but I am just giving you some summary, some very important find that you will likely get in your exam. So first of all, anesthesia is a triad of man. What I mean by this is MAN. M for muscle relaxation, A for analgesia, and for narcosis. Now, we have a risk estimation for anesthesia and surgery that is given by ASA grading system. Now, the ASA grading system has six classes, and I like to remember them as one being perfect, two having mild systemic disease like for example controlled hypertension. Then we have three that has uncontrolled hypertension, and then there is four that is uncontrolled and has caused systemic problems, may cause of stroke, may cause of cardiac disease, may cause a lot of problems. That is your grade 4. And then grade 5 is the patient that cannot be expected to survive without an operation, and grade 6 is obviously the patient is dead. So these are your ASA grading. Now we have now I will talk about how we induce anesthesia. So first of all, uh, the most it basically the induction can be by intravenous agent or inhalation agents as well, but intravenous agents are most commonly used. The most commonly used is your propofol. Thiopentone is more useful in neurosurgery as it decreases the intracranial pressure. Then you have ethimidate. It has good hemodynamic stability, but it causes adrenocortical depression. Then there is ketamine. It is ideal for field anesthesia because it preserves BP and respiratory reflexes, but it can cause uh, emergence delirium. Now, we can basically induce anesthesia by two ways. First of all, we can do a rapid sequence induction or total intravenous anesthesia. In rapid sequence, we use thiopental plus succinylcholine, which are thiopental is basically for induction, and succinylcholine for muscle relaxation, and it basically gives the anesthesia within 30 seconds. Yeah, within 30 seconds, and the patient can be intubated between 60 to 90 seconds. And obviously as such, you can say that the speed, it is obviously used for emergency surgery. Now there is also total intravenous anesthesia, that is known as TIVA, in which you will give propofol and ultra-short-acting opioid at remifentanil. It is usually used for daycare or neurosurgical procedure. It has better hemodynamic stability than the above mentioned rapid sequence induction. Now, there are two types of muscle relaxation. These are depolarizing or non-depolarizing. Depolarizing, such as succinylcholine, are used for rapid sequence induction, but it causes hyperkalemia, hypertension, myoglobinemia, and malignant hyperthermia. And it is contraindicated especially in the burns patient because they have hyperkalemia. The non-depolarization, you have atrochronium or virochronium, and it is usually paired. It is reversed by your neostigmine along with atropine. Now, the atraconium is you can give in CKD and DCLD patient, but it is allergic, while viroconium is not allergic, but you cannot give in CKD or DCLD patient. And now, how you will maintain anesthesia? So there are two ways. Either you can do intravenous or you can do inhalation, but inhalation is used more often. In intravenous, you have propofol that is given in continuous infusion, or your inhalation agents are your halotene, nitrous oxide, isoflurane, influrane. Now, nitric oxide. The problem with nitric oxide is that it causes myelosuppression and megaloblastic anemia. Otherwise, and it is a potent analgesic but a weak anesthetic. Halothane basically causes hepatotoxicity and hyperthermia and can cause respiratory depression because it is also negative inotropic. Isoflurane is the anesthetic of choice in most surgical processes, but it can cause coronary streal syndrome. Now, while the maintenance of anesthesia, you have to monitor the patient. You have continuously have to monitor the ECG and the blood pressure, and also the adequacy of the ventilation, the inspired oxygen concentration, and the end tidal carbon monoxide concentration. The drop of like 20 to 30% of MAP is completely acceptable, and it is not a problem during anesthesia. Now, moving on to the local anesthetics, the most common are your lidocaine, bupivacaine, ropivacaine, lidocaine. Basically, you have to remember that with adrenaline you can give a larger dose of the anesthetic, and like if the lidocaine is given like 3 milligram, the maximum limit of lidocaine is 3 mg per kg. The maximum limit with adrenaline is 7 mg per kg. With adrenaline, the potency is usually increased, but the toxicity is also decreased. Bupivacaine is cardiotoxic and should not be given intravenously. Never. Now, if the wound is infected and you apply the local anesthetic around it, it will not work. It will not work because obviously the acidic condition make it ineffective, because local anesthetics are themselves acidic, and they they basically work by work by infiltrating the base that is released by the relative alkalinity of the tissues. But if the local anesthetic is stored in acidic solution, and the area you are working with is also acidic, the it will no longer work. Now, moving on to the spinal anesthesia. Spinal anesthesia causes spinal headache, and basically it's a single shot that blocks the spinal nerve roots, dorsal root ganglia, and it should be limited to surgeries below the segmental level of T10, because if you ascend too much it will cause hypotension and mentality failure. Now, it causes a spinal headache, but you can prevent it, and you can even treat it by blood patch epidural injection, in which you take 5 to 10 ml of the blood of the patient and inject it at the site. Now, epidural anesthesia is now moving on to the epidural anesthesia. It is better if you have to have a prolonged post-op anesthesia to the patient, because you can have intervening catheter that is into epidural space. Now, it uh, it does not produce adequate analgesia for surgical intervention, but it is ideal for post-operative pain. Now, epidural anesthesia can cause epidural hematoma as well, so you have to avoid low molecular weight heparin before and after the procedure. If the patient is receiving low molecular weight heparin, so that should be stopped 12 hours before and at least 2 hours after the procedure. Now, moving on to the TAP, transverse abdominis plane block, in which you go between the internal oblique and transverse abdominal muscle. You block the T6 to L1 nerve, and it is effective analgesia for like wide range of abdominal surgery, and it increases time for before you can give further analgesia. Then there is Bayer block, which is intravenous regional anesthesia. You basically make inflate the BB cuff around the patient hand, and it is usually done in upper limb, not in the lower limb, because in lower limb the larger quantity you will require larger quantity, it will cause systematic problems. So in upper limb you make the cuff, you inflate the cuff, and then you will give your intravenously, for example, pilocaine, in which is the safest agent to use, into the vein, and you will basically inflate the and you will inflate the cup. Then you will give the prelocaine 0.5, but that is the safest drug to use. You cannot use bupivacaine because the cardiac arrest is called cardiac arrest. And the distal cuff should not be basically deflated for 20 minutes to prevent systemic toxicity. Now the pain management. Okay, so if the patient is for example have a systematic disease, for example cancer with metastasis that he cannot survive, so we divide the patient into two types. For first is chronic benign pain. For they have a lifespan of 2 years, but they cannot be treated basically. Then in chronic malignant pain, if they have less than expectancy of less than 2 years, but they and also they cannot be treated. So you will basically give you have many agents. The agent for chronic benign pain, the most common agent for chronic pain is paracetamol, NSAIDs, and pregabalin and gabapentin, and obviously opioids. Slow preparation of opioids, such as slow release preparation of opioids such as morphine or oxycodone. In malignant, you will also do the same. The step 1 will be to give paracetamol, NSAID. Step 2, to go weaker opioids like codeine, tramadol, and then the oral morphine. And you don't care about the addiction part because the patient is even unlikely to survive. There are also neurolytic treatment where you do a subcostal phenol injection if there is metastasis, celiac praxis block for gastric, pancreatic, or hepatic cancer, percutaneous scototomy to basically stop the spinothalamic tract pain pathway to the spinothalamic tract.